second lecture, which is EUS-guided radiofrequency ablation of pancreatic neoplasm. I think this technique is a very promising technique in special situations, which I think neuroendocrine tumors, especially functioning neuroendocrine tumors like insulinoma and gastrinoma, it will be a very, very promising technique to avoid major surgery. Before going through these subjects, I'd like to share you some of short videos to know the magnitude of the problem. This short video represents a 37 years old man with frequent attacks of hypoglycemia, severe attacks of hypoglycemia necessitating frequent ICU admission. During the attacks, there is severe hypoglycemia, and the insulin and the C-peptide level are mildly elevated. So it is a proper and the classic clinical and lab situation of insulinoma. Endoscopic ultrasound revealed this very nicely well-defined small mass at the region of the venous confluence. This is a very small mass, about 1.3 by 1.5 centimeter at the venous confluence, and the management of this patient is, of course, surgical excision. And here the operation is very difficult because the tumor is small, deeply seated, and the surgery will be extended Whipple operation or extended distal pancreatectomy. So these patients managed by a major surgery because although it is a very benign tumor in selenoma and never metastasized, never metastasized, but it produces very severe hypoglycemic attacks, which is dangerous for the patients. This is another patient of a 35-year-old female with dull aching pains, not responding to spasmolytics or proton pump inhibitors, and endoscopic ultrasound revealed this very small mass at the region of the pancreatic body. This is the left kidney, and this is part of the pancreatic body, and this is a very small mass, about 1 centimeter by 1 centimeter. But because the mass is symptomatic, producing pains, irritating the patient, so this patient should be managed by surgical excision of this mass, and here the operation will be distal pancreatectomy. This is a third patient presenting with repeated attacks of acute pancreatitis, and endoscopic ultrasound revealed this rather small cyst at the region of the pancreatic tail. This is the spleen, so we are in the region of the pancreatic tail, and here we notice that there is nicely seen mural nodule, which is a very grave sign of malignant potentiality of this cyst. And this cyst, despite small, but have a high malignant potentiality and also severely symptomatic by recurrent attacks of acute pancreatitis, so it should be surgically removed, and here the operation will be distal pancreatectomy. Whipple operation has a mortality about 5 to 10% in best centers all over the world. In the Scandinavian centers, the mortality is about 10%, and the morbidity is very high, really, 30 to 50%. Distal pancreatectomy has a leakage rate up to 30%, and the enucleation of the tumor had a complication of fistula formation in up to 30%. So what I'd like to say is that sometimes we are obliged to do major surgery with high rate of morbidity and mortality for small, mostly benign tumors. In addition, patients may be poor surgical risk due to comorbidities, and some patients are refusing major surgery. So other modalities should be searched for in all these situations. Why not doing radiofrequency ablation? We all know the radiofrequency ablation of hepatic focal lesion, whether primary, small primary HCC, or single metastasis. Radiofrequency ablation is now a curative procedure has a cure rate, why not producing EUS-guided radiofrequency ablation by a special probe going through the echo endoscope and ablating this small tumor instead of doing major surgery with high morbidity and mortality. Let us have a short brief about the history of radiofrequency ablation. The basic technique of radiofrequency ablation was described over a century ago by Dr. Zonval, who in 1891 first demonstrated that when radiofrequency waves pass through the tissue, they produce an increase in tissue temperature. In 1910, Beer described a new method for the treatment of urinary bladder neoplasm using radiofrequency ablation through a cystoscope. Radiofrequency ablation works by causing ionic agitation of the tissues surrounding the needle. The shaft of the needle does not produce heat actually, but rather the heat is produced in the tissues, and that leads to coagulation and cellular necrosis. When the temperature in the tissue, in the tumor, raises to 42, from 42 to 45, thermal injury starts. When the temperature reaches 46, there will be irreversible cellular damage at 60 minutes. When the temperature raises to 50 to 52 degrees centigrade, irreversible cellular damage occurs in about 4 to 6 minutes. When it reaches 60 degrees centigrade, there will be instantaneous cell death. And the boiling, of course, is at 100 degrees centigrade. So the ideal ablation temperature is between 60 and 100 degrees centigrade. So we made the circuit of the patient, the earthing at his leg, the generator, and introduce the probe and start to apply electricity by watt for many seconds, and this raises the temperature from 60 to 100% to produce ablation and instantaneous cell death of the tumor. Actually, today we will talk about radiofrequency ablation through endoscopic ultrasound of pancreatic tumors, but actually there are two types of radiofrequency ablation. The first one is ELRA, endoluminal radiofrequency ablation, applied through the duodenoscope through ERCP, and the topic of today is EUSRA, is endoscopic ultrasound radiofrequency ablation through the EUS. This is ELRA, endoluminal radiofrequency ablation through the duodenoscope during ERCP and cannulating. This is a usual duodenoscope and cannulating the papilla by the probe of radiofrequency ablation, and it managing centralization of the probe into the cholangiocarcinoma, and this is a palliative procedure for cholangiocarcinoma and also widening the lumen and prevent stricture. Now we will talk about the endoscopic ultrasound guided radiofrequency ablation. This is our subjects. What is the potential application of endoscopic ultrasound guided radiofrequency ablation? First, we can apply it to pancreatic tumor, especially pancreatic duct adenocarcinoma, and very nicely and very effectively in pancreatic neuroendocrine tumor, and also very effectively in cystic neoplasm like IPMN and mucinous cystic neoplasm. We can apply it to hepatocellular carcinoma through echo endoscope because, as we mentioned before, endoscopic ultrasound can examine the liver thoroughly, and also for solitary or two liver metastases or few liver metastases, we can apply it to metastatic lymph node. We can apply it to GIST tumor in the stomach, esophagus, or the duodenum. GIST is, of course, very rare in the esophagus. Can apply it in GIST in the stomach or the duodenum, and also in adrenal gland tumor. As Dr. Anna said, we can apply it for celiac plexus neurolysis, proved to be very effective, but needs more patients to verify its role in that context. I think the most applicable and the most successful value of EUS-guided radiofrequency ablation is its application in pancreatic neuroendocrine tumor, and pancreatic cystic lesion. It reduces or eliminates the risk of progression to invasive cancer and avoiding the risk of pancreatic resection, avoiding doing major surgery.
Mhm.
We can apply it to pancreatic net less than 2 centimeter. Pancreatic net more than 2 centimeters should be sent for surgery till now, or we can apply it to neuroendocrine tumor more than 2 centimeters in surgically unfit patients. This is very suitable in insulinoma, gastrinoma, vipoma, and somatostatinoma, especially in insulinoma. Insulinoma is a very benign disease, uh, very rare to metastasize. So if we apply radiofrequency ablation and I succeeded to distract 90 or 95% or even 80% of the volume of the tumor, so I can get rid of 90% of the symptomatology of the patients. So the attacks of hypoglycemia, the lethal attacks of hypoglycemia will be very less frequent, very shorter in duration, and very less in severity. So it is ideal here in insulinoma instead of doing major surgery for a small benign tumor. Also in pancreatic cysts, especially IPMN, especially those presenting by acute pancreatitis, they are should be surgically removed. Instead of doing major surgery for a small cyst, I can apply radiofrequency ablation, and also for mucinous cystic neoplasm. Then what is the rationale in other tumors in pancreatic adenocarcinoma? Pancreatic cancer may be resectable, and this should be sent for surgery. Radical surgery is the standard of care in resectable adenoduct adenocarcinoma of the pancreas. It may be borderline resectable, and here the management is neoadjuvant chemotherapy for downstaging. Could we use radiofrequency ablation for downstaging? It was used, but till now it is not successful. Pancreatic cancer may be locally advanced and resectable, and this will be sent for palliative chemotherapy. Why not doing radiofrequency ablation? Locally advanced, we can do chemotherapy and radiation in locally advanced unresectable tumor, but why not trying EUS radiofrequency ablation? Because actually in this context, in this point, it produces two beneficial effects. The first one is direct immediate effect, lethal coagulation necrosis, and the second is indirect delayed effect when the temperature in the tumor raised to 41 to 50. It produces inflammatory immune response, hyperemia, so sensitize the tumor to adjuvant therapy. So when I combine both chemotherapy and radiofrequency ablation in inoperable or locally advanced pancreas, the action of two is a augmentation, not just a summation, because radiofrequency ablation irritates the tumor, inducing inflammatory response and sensitize the tumor to the chemotherapy. So the tumor actually decreases in size, may increase the resection rate, may produce downstaging, but till now this effect is not proved because we need large number of cases and reduce metastasis. And it may be used as a treatment, of course, of local recurrence after surgery. The patient did not do surgery if there is recurrence of cancer pancreas. So the advantages of EUS radiofrequency ablation is that it is minimally invasive. We can repeat it twice or thrice. No cumulative toxicity with chemotherapy. Short-term recovery after the procedure. The patient may do the procedure in one-day basis and go home at the end of the day, and can be combined with chemo and radiotherapy because both effects are augmentation and not just summation. What is the side effects of radiofrequency ablation? There is potential adverse event. The most important is damage of nearby structures. If there is damage of the common bile duct, there will be an obstructive jaundice. If damage of the duodenum, it can lead to perforation. If we damage the nearby main pancreatic duct or a large side branch of the pancreatic duct, it can lead to pancreatitis, fistula, and ascites. So we should adjust the ablative volume to the actual volume of the tumor. How we can adjust the watt, the electricity, electric power of the watt, and the duration of application. If we apply 50 watt, for example, for 10 seconds, then we can ablate a mass measuring 10 by 12 millimeter, and so on. If we apply 10 watt for 180 seconds, we can ablate a tumor measuring 15 by 15 millimeter. So by adjusting the ablative volume to the actual volume of the tumor, we secure that there is no extension of the heat effect to the surrounding structure, and so avoiding complications. Now coming to the articles or studies in the world, the most famous is the French multi-center study in Marseille by Marc Partey and Marc Giovannini. Patients included are poor surgical risk patients, included mucinous cystadenoma, intraductal papillary mucinous neoplasm with worrisome features, neuroendocrine tumors about 1 to 2 centimeter, as I mentioned before. This study was planned for 30 patients during 2 years and follow up for 1 year. What is the result of this study? 12 patients with NET at 6 months. There is significant response in 82% of the patients. 7 patients has complete necrosis and appearance of their neuroendocrine tumor. 2 had diameter decreased more than 50%. 2 had a diameter decreased less than 50%, and 1 complete failure. At 12 months, no recurrence occurred in responder patients. Regarding the pancreatic cyst, 13 patients among 16 with intraductal papillary mucinous neoplasia were followed for at least 6 months. At 6 months, there is significant response in 69% of patients. 7 patients had complete resolution of their cysts. In 2 patients, the diameter decreased more than 50%. 3 had complete failure, and the mural nodules disappeared in 10 cases among 12 cases. At 12 months, results remained stable. 1 year ago, we started our experience of radiofrequency ablation in Egypt. We started by 3 cases, 2 cases with unresectable pancreatic duct adenocarcinoma as a palliative therapy, and a case of insulinoma. The first case was a 55 years old patient with pancreatic duct adenocarcinoma. The second patient was a 47 years old patient with aggressive pancreatic body duct adenocarcinoma. And the third one, the man who, as we saw his video in the first of the lecture, is a 37-year-old man with insulinoma. 7 passes was done in the 3 patients with ablation as multiple levels, and we used 19G cooling EUSRA needles from Taiwan, South Korea. This is one of our patients with advanced pancreatic head mass. There were extensive collaterals due to invasion of the portal venous confluence. This makes things a little bit difficult, but finally we have a terminal, we have a portal of entry among these extensive collaterals. Okay, yes, this is the needle here, and this is the mass, and this is the common bile duct, the obstructed common bile duct. And here, this is the needle. Yes, we centralize the needle at the center of the mass and start to do many applications. We use 16 watt for 10 seconds. Here, this is the bubbles, the whitish bubbles of gases results from ablation, exactly like radiofrequency ablation of the liver, and starts to ablate 3 or 4 areas of the tumor to decrease the tumor volume. It is just a palliative maneuver, but it has, as I previously said, an additional effect is inducing inflammation and sensitizing the tumor to the palliative chemotherapy. Regarding these cases, no complications or mortality, no post-procedural pain. That is very nice, but at the end it is just 3 cases. But actually there is no pains. This is was a surprise for me. I expected to have some pains. There is a decrease in about 50% of the volume in both cases. However, no down staging allowing radical surgical excision occurred. So it is just a palliative therapy. No metastasis or mortality up to 4 months after the procedure. 12 months ago, we did the third case and the first EUS radiofrequency ablation in an insulinoma in a 37 years old male refusing to do major surgery. These patients had severe attacks, really severe attacks of hypoglycemia necessitating ICU admission several times and frequent fallings and frequent injuries from the severe attacks of hypoglycemia. He has a very small tumor, about 1.2 millimeter or 1.3 millimeter. And during frequency ablation, avoid the pancreatic duct. Avoid injuring the pancreatic duct, and of course avoid the major vessels. We applied 40 watt, a little bit lesser than the duct adenocarcinoma, and we introduce the tip of the needle in the center of the mass, and starting to do radiofrequency ablation. I applied 3 times radiofrequency ablation at 3 entries, and ablating 3 areas in the mass. And then we will now start the procedure, and you notice here that there is burning of the tissue and the vapors and the gas arises, so inducing necrosis and ablating a large volume of the tumor. The follow-up of the patient has no bouts of clinically significant hypoglycemia over the 4 weeks follow-up of radiofrequency ablation. There is marked improvement. No attacks of that severe attacks recur, but over the following months, there were 3 bouts of hypoglycemia necessitating intravenous glucose infusion, but not necessitating ICU admission. So another session of EUS radiofrequency ablation was planned by the moving shot technique. This is the moving shot technique to introduce the needle to the most distal part, not at the distal border, but at the distal part, and try to apply current, and then withdraw the needle, and another application, and a third application, as much application as we can. This is the moving shot technique. Okay, and here, this is the same patient. This is the same patient with application of many applications. And fortunately enough, there is no attacks. The patient is free till now for 1 hour, for 1 year. But in these patients, we did the procedure twice. So we may did it once or twice or even to the third time. So take-home messages. EUS radiofrequency ablation is a promising technique for small neuroendocrine tumors to avoid major surgery with significant morbidity and mortality. It is especially indicated in surgically unfit patients or patients refusing surgery. However, more comparative studies are needed before recommending EUS radiofrequency ablation as an alternative therapy to surgery for operable pancreatic masses, or as an alternative to chemotherapy in inoperable pancreatic masses. And thanks for your attention.
Thank you, Professor Hussein, for such a very nice presentation and the very demonstrative videos and animations to such uprising technique. Now, there are some few questions for this lecture, so if you may give you the questions.
We still have 4 minutes.
Okay,
4 minutes. We should be in time, so we will apply one.
If I could
Uh,
once
wha-
Dr.
again
Anna, she wants to comment.
congratulate.
so, and the rest
Professor
of
Anna wants
questions
to
will be
comment.
at the end of the lecture.
Okay.
Dr. Anna
Yeah,
wants to ask something.
congratulations for excellent lecture and amazing pictures. And I would like to share my patients, above 10 patients, and we rather recommend this for the neuroendocrine tumors, and you told, and metastasis of the kidney. Yes, so with very good results, also not only for insulinoma, but also neuroendocrine tumor without hormonal activity between 1 and 2 centimeters, which are not qualified for surgery and which shouldn't be observed follow-up lower than 1 centimeter. So maybe it's also the future for this kind of treatment.
So we may do multi-center studies. This is the fourth or fifth multi-center study between Egypt and Poland. You have 10 cases?
Yeah.
More than about 12 now. We are planning because we bought the equipment and now we start with more patients. Now we have 12 patients and only neuroendocrine and only metastasis from the kidney. Yes, so we don't have any experience when it comes to adenocarcinoma.
Then very nice. Then you have 12 cases. I had only 3. So we may do multi-center study and you will be the boss.
We could think about our together with Professor Barthe maybe, and we will.
With Professor
Barthe.
Marc Partey from Marseille.
Yeah, we will. But we can
Yes.
cooperate. I have a huge will for this kind of cooperation. Multi-center study are the future, I'm sure.
Yes, and congratulations for this rather large number of cases in that very rare technique or newly emerging technique. Congratulations.
But the future, I'm sure that it's rather safety and efficient, because in our when we observe the patient after every 6 and 3 months, always we find necrosis. For example, one patient has the liquid instead of neuroendocrine tumor, and we have, a scar instead without any, and we check the result in the examination with contrast enhanced with sonoview, yes, and we don't find any bloods and any Doppler signals from this tumor after treatment.
Yes, very